All right. Welcome everyone to our PrEP Financing Learning Collaborative session on long-acting injectable PrEP financing and logistics. So I want us, first of all, to just establish the fact that injectable PrEP is very new to us all, and that we will likely end the day or the seminar here today with still having quite a few questions that aren't answered. I'm hoping that we do get a lot of questions answered today, and I acknowledge that there are probably some people in the room here today who will have some answers to questions that maybe our different presenters don't. We're fitting in a lot into this 90 minutes, so I apologize in advance if it feels rushed. Please put your questions and comments in the chat, and we will be keeping track of them. And then when we have our panel discussion, we will address your comments and questions. We also are recording this, and we will post the recording on our Learning Collaborative website. I'll put that a couple times into the chat. And we also will have some resources that some of our providers have given us to post, including a draft injectable PrEP protocol and some other useful information. I think that that's all I have to say by way of introduction. So if I could, Liz, maybe could you take our poll down? And I'll introduce my colleague from the California Prevention Training Center, who is going to give us a little bit of an introduction to injectable PrEP. Tamara Ooms is a nurse practitioner and works for the California Prevention Training Center as a clinical consultant and program manager. She has worked in sexual and reproductive health for over 20 years as a clinician, consultant, manager, and educator. Take it away, Tamara.
Thanks, Robert. Hi, everyone. I recognize many names that have popped up from the waiting room, so I'm so glad everyone's here today. I just want to give a very brief overview of the timeline for injectable PrEP. So I put this together. It's a pictorial just to give you a visual of what's required per CDC guidelines for evaluation and monitoring. This is not by any means a detailed clinical timeline, so please don't pass this on to your clinicians necessarily, because, for example, STD screenings recommendations vary depending on patient risk factors, et cetera. But I just wanted to sketch it out so when we put it in the context of access and financing, we know really exactly what services patients need access to and what costs may be associated with each of these services at each of these time points. So you can see here that, our starting time point, and that may be the first time a patient may start the same day, although as we'll talk about, that's going to be really tricky for injectable PrEP, unfortunately. Or it may be that the first visit is going to predate that start, so that initiation visit, as we call it. And after that initiation visit, there's basically 1 month follow-up is required for the second injection. And then after that, it's basically every 2 months, assuming patients stay on the trajectory. So what's important about this is that really we're looking at a number of things at each of these visits, each of these time points. So initiation visits often require a clinician evaluation, right? And then we have HIV testing, often STD testing, hopefully, plus or minus other labs you might be doing, like screening for hepatitis C or hepatitis B. But basically at each of these time points, labs are required, acquisition of medication is required, and an injection of the medication, right? Those are kind of the minimum. So then you may have clinician evaluations that are thrown in at various time points, and my guess is that's going to vary depending on the clinic, the workflows. What Kaiser may be doing is going to be different than what a community STD clinic may be doing, for example. but we all know that costs differ depending on who sees the patient and what services the patient receives. So medication acquisition is really going to be a big hurdle in many settings. And we'll talk about that more in a bit, but really important to think about. It's not as easy, right, as getting oral PrEP. And then because of the long-acting nature of the injectable medication cabotegravir, it's really important to do something different than many clinics have been doing with oral PrEP, and that's to exclude an acute HIV infection, which is a new infection, right, that the patient gets during the treatment with injectable PrEP. And we need to exclude it with an HIV RNA test. And for those of you that aren't familiar with that term, it's a test that looks specifically for the virus itself and not for the antibodies to that virus. And there are many clinics that are doing HIV RNA tests, I realize, but there are many that are not. It's tricky. It's traditionally a lab test that requires a blood draw, and it gets sent out usually, depending on your setting, and often reported back later. So it's not usually a point of care test, although I know there may be one version or a couple versions of those currently on the market. Chris Hall can probably speak to that better than I, but it's tricky. It's a very different way of testing than many settings are used to. So it can be a really big lift. And it's also a very expensive test in many settings. So just these are kind of the important hurdles that I'm pointing out here. And then I think a big question with all of this is, are payers like private insurance going to agree to pay for 7 RNA tests in 1 year? Because that's what you're really looking at when you look at this timeline. All right, so what else did I want to say about this? Yeah, I think that's it. So you can see there's a lot of different things that patients need access to, lots of costs associated with them. And then if a patient missed an injection, they have to restart with 2 injections, again, that are 4 weeks apart, which could then add more visits. And I think for many of the patients we are hoping will get access to injectable PrEP, there may be some stopping and starting that happens. So yeah, that's just what I wanted to relay to kind of kick this off. And I will send it back to Robert.
Okay. I wanted to talk a little bit about some financing. 1 second, and I'll share my screen. So I wanted to just talk a little bit about what we know about what's required, what will be required of navigators and providers for insured individuals. Navigators, we hope, or staff at our clinics will need to ascertain what kind of coverage that the insurer provides to our patient. And this, of course, is going to vary by company and state. It's likely that most insurance companies are going to require prior authorizations or statements of medical necessity. We have heard from several providers already that getting approval from insurers has been challenging. People have been turned down more than once for this. And so I think that's going to be a big piece of advocacy that we see in our futures. The insurance benefits will vary if this is approved, depending on whether the insurance policy classifies this as a medical or a drug benefit. What that means briefly is that if it's classified as a drug benefit, the insurance might only cover the drug and might not cover the associated care costs. Whereas a medical benefit would likely cover some part of all of the services and the medication. The challenge is that the medication will need to be, once the patient's approved, the medication will need to be shipped from the provider by the specialty pharmacy associated with that insurance provider. And so in my estimation of this, it's going to be kind of unusual that a patient would be able to get the first injection within a week of putting through the request to the insurance company.
So it's dot.
The company that manufactures the drug, Operitude, is ViiV, and they are offering a copay card, $7,500 for the medication itself and $350 for any associated administrative costs, which allow, I believe, the pharmacy to also recoup some money from the insurer. It's going to be probably easier for us to provide injectable PrEP to our uninsured clients and patients. The ViiV Patient Assistance Program eligibility is the same as Gilead's is for their 2 PrEP drugs. You must be able to provide a US address. You need to earn up to 500% of the federal poverty level and have no insurance, specifically no drug coverage. For people with Medicare, they need to have met their $600 a year out-of-pocket deductible. I'm going to show you the application in a second. I'm advised by some people at ViiV that at this point, their online portal is not very responsive, and that the best way to complete the application is to print it out, fill it in, and fax it back to ViiV Connect. I think if everything goes smoothly in this process, if we ascertain in advance that our patient or client will be eligible for this and we don't have any delays there, ViiV Connect says that they'll approve the application within 2 days. Once approved, they will arrange for the shipment to the provider from their specialty pharmacy. People at ViiV assure me that it will arrive in 2 to 4 days. And so it would be possible to give the first injection within the 7 days. And I'm going to mention why I'm talking about 7 days in a second. And then finally, as I said at the beginning, we have, we still have a lot of questions. The reason I talked about the 7 days is that it's been the standard protocol to have an HIV negative result within 7 days of initiating oral PrEP. And I don't see any reason why that would be different for injectable PrEP. So as we saw, especially with insured people, if the drug does not arrive within 7 days, does that mean then we're going to have to retest the person for HIV? And then, of course, with that retest, if the person is wanting insurance to pay, we'll have a question of whether they will pay. As Tamara said, will insurers pay for up to possibly 7 HIV RNA tests a year? By my estimation, stocking the drug will not be feasible for most settings because even the 340B price is quite high, a little over $2,800. So very few organizations and clinics are going to be able to buy a lot of drug to keep on hand in order to maybe make some of these logistics a little bit easier. It will be very important for you to meet your ViiV field reimbursement manager. This person is not a sort of quote unquote pharma rep of the type that wants to buy us lunch so that we'll prescribe their products. This is the person whose job it is to help make access to their products smooth. We had planned to have one of them with us today. However, he notified me this morning that he had something else come up today. So the one thing I will do that he was going to do is just quickly show you the patient assistance program application. And then my final question here is, I think the one that we're all asking is, will injectable PrEP address the gaps in PrEP access and retention that we are currently having with oral PrEP? Or will it just be another product for the people who already have an easy time of accessing oral PrEP? So 1 second, and I'm going to show you the ViiV application. So here we are, fairly typical of this sort of thing. Ask for patient information. asks for prescriber information, not only the prescriber's information itself, but then information about the site and where the injections will be given. And then an additional enrollment form with some sort of like just a prescription on it that the prescriber fills out. And then they asked for information. Did I scroll past that? They asked for information on the person's financial circumstances. Sorry to scroll through too quickly there. Yeah, this is where they ask about your patient's financial circumstances. So that's the end of what I'm going to say now. I am very happy to introduce our first presenter. She is Jillian Narcisse, a clinical pharmacist at the University of Miami. Jillian was born in Haiti and moved to the US 22 years ago and has been working with the University of Miami PrEP program since its inception in September 2018. So you're on, Jillian.
Hello, good afternoon, everybody. I'm trying to put my slides up. There we go. Can you see my screen? Can you see it?
Yes,
we can.
Perfect.
Just to make sure. So good afternoon, everybody. My name is Jillian, and I've been with the program since 2018. I've started the very first PrEP patient with Truvada, and Descovy, and now Aphrodite is our new drug that we were trying to navigate at this time. So I'm gonna go over, so I'm gonna go over our program and our 3 patients that we have, our first 3 test patients that we have tried so far, and just some takeaways from this experience. So go back. So our program started in September 2018 with Dr. Suzanne Doblecki-Lewis. She is our program director, and she is now the chief of our division. And this started as a grant from the Florida Health Department to go out in communities and do mobile PrEP in different areas of Miami, in the needed areas of Miami. So we worked with the health department to find out the high cases of HIV incidence areas, and we tried to have contracts with locations in those areas to have a mobile vehicle go to those sites and provide PrEP services. And we started with because we didn't have a vehicle back then. So we went with the Cancer Center, and we did this prevention services, doing HIV prevention and also cancer prevention through cancer screenings. Eventually, we expanded and had enough funding to get our own vehicle. And now we have expanded, we have our own clinic within the university. And last Friday, we just opened a PrEP clinic within a Walgreens in Miami Beach, which is a high incidence area for HIV. So our key services are, we provide PrEP, we do NPEP, we do Genwell. All right, so our key services, we do PrEP, we provide NPEP, as well. We have a Genwell clinic for transgender patients. So we provide hormone treatment and PrEP to those patients as well. And also we do have a rapid start the HIV treatment program that was started last year. So we have grown since 2018. And within our program, we have seen since 2018 about 1,300 patients. and approximately 450 starts. So for that number, the first number is more. So we've seen 1,300 checking for HIV testing, screening, or STD screening and testing, and then 450 have started on PrEP. The majority of our patients are Hispanic Latinx community, about 63%, and the age range is from 18 to 68. We have older patients on PrEP as well. So this is our first day that we started our program with the on Miami Beach. So that was our grand opening with the Game Changers. So we worked with the Cancer Center, and that was their vehicle. We shared the vehicle with them to provide HIV and cancer screening. And this is our new mobile. And if you ever see us, if you are in Miami area, we do go out in different areas in Miami Beach, Liberty City, Homestead, Florida City area to provide, and also Hialeah. So we go to those sites to provide PrEP services. And this was the grand opening of our clinic in Miami Beach last Friday. So when this first came up, so we had to make up a plan out how to roll out to start the PrEP opportunity. So my first step was to go to my VREP. We didn't have one. I knew one from HIV, and then they guided the one for opportunity. They have one just for that medication. And our first challenge was to figure out the insurance plans that are onboarding and accepting the plans that are accepting Apertude. So we met with the VREP, and when we first met her, we only had 2 plans that were paying for Apertude. So what we did was we went through our patient list to figure out which of them had those insurances, and just meet with one of each plan and one uninsured patient. So one uninsured patient, and we went about drafting a standard operating procedure for this medication. And so right now we've had 3 test patients, what I'm going to talk about in the next few slides. And as far as the rapid testing, so before the injectable, so we are opting to go with the Alere 4th gen test. And so we're still ongoing. And actually, so we've had 2 injections so far. We had our first patient yesterday, and we have our second one going on about this time right now. So that's big progress. So once we've done all 3 test patients, we're gonna roll out our full implementation and finalize our standard operating procedures. So the VREP told me that the only plans that did accept Apertude were Humana and Blue Cross Blue Shield. So we found our first Humana patient, and so we started the investigation benefits through VIV Connect on February 25th. And a prior authorization was needed, and there were some pharmacy restrictions. So they had to use Humana specialty pharmacy. So I submitted the prior authorization. It was approved. However, because that patient had been using Walgreens pharmacy the whole time, but because they had been using the Humana because of the restriction, the pharmacy needed to contact them, and that took about 2 weeks to get that patient because they weren't answering their phone because the phone number. I tried to email them, they weren't answering, and finally they answered, and the medication was shipped. And the day after we spoke to the insurance, they lost the insurance because they started a new job. So we received the shipment on 4/8, but they are getting a new insurance, which is the same plan on May 1st. So we scheduled them to get their injection at the end of this month so that when the new insurance kicks in, we can get the prior auth started on May 1st to get to have the injection ready by the next time he needs his second injection. So he was to come yesterday, but he didn't show up. But hopefully he will get it sometime the next couple of days. Hopefully he'll call us back for his injection. Our second injection was uninsured. It was pretty easy. So I did the Beef Connect application. It started on April 1st. We got the medication on April 15, and they got their injection yesterday. That was fairly simple. They didn't have any income. I wrote a letter of income for them, and that was fairly easy, very easy patient. And then patient number 3 has Florida Blue, so which is Blue Cross Blue Shield as well. So we did the Beef Connect application. It needed a prior authorization, and there were also some pharmacy restrictions. He had been using Walgreens for a long time. He go to CVS. When we did send so it's not needed a prior authorization, which I completed through our portal called Cover My Meds. When I did that, I was told that it's not a pharmacy benefit. But when Beef Connect did say it was a pharmacy benefit, so there were some back and forth. It took me about a good 2 weeks to even figure it out, because even the pharmacy didn't have a bill for it. They were still like, they didn't know what to do. So I reached out to my Beef field reimbursement manager, and I told her of the situation, and she got it to go through for me. And so we got mentioned yesterday, and he's getting it. He's getting his first injection. So takeaways, I would say, really, at least for us, is really get to know your specialty pharmacies. They are really good, and they're very helpful. We work closely with ours in the area. They know me, they know our office, they know how to contact us if there are any issues with the patients. And Beef Connect is your best friend. They will help you, with anything to get for insurance purposes. And if you have any issues, just reach out to your field reimbursement manager, and also connect with your ViiV rep. They are really very helpful. They guide you through the whole process. And also having an on-site pharmacist that is very helpful to help navigate the process. And over here, so this is we were at the Pride Festival that was last year. Now this is our team. Thank you.
Thank you so much, Jillian, and apologies to everyone for the hackers that have been interrupting us. So one thing I think we saw is that with Jillian's 3 patients is that it does sort of give us proof of what we talked about, the timeline for the logistics of this, is that it is going to seem to be pretty difficult to give people their first injection within 7 days of that HIV test. As far as the question about the extra charge to shipping to Alaska, I think that would be something that your access manager could address. So I'll add at this point that anyone who wants to be connected with their ViiV access manager is welcome to contact me, and I'll put you through to the right people. So thank you, Jillian. Let's move on. And I want to introduce our next 2 presenters. Caroline Sacco started working as a PrEP nurse for the Baltimore City Health Department in 2019. She graduated from Swarthmore College with a bachelor's in education, and later earned her master's in nursing science from Johns Hopkins University. Caroline was recently promoted to senior clinical nurse to lead the injectable PrEP rollout. She is passionate about patient care and health equity in Baltimore. She's joined by her colleague, Shauna Dell, who received a BS in biochemistry from Beloit College and a Bachelor of Science in Nursing from Johns Hopkins School of Nursing, and an MPH from Johns Hopkins Bloomberg School of Public Health. She has been working on developing PrEP programs since PrEP was approved in 2012, and she currently serves a joint role as the PrEP STI clinic nurse manager at the Baltimore City Health Department and the protocol specialist with the Johns Hopkins PTC, Prevention Training Center. Okay, welcome, Caroline and Shauna.
So thanks everyone so much for having us. I have been working at the health department since 2019, and we were really excited when CAB got approved, and jumped right into figuring out how to implement it in our clinic. So next slide, please. So just to give you a little bit of a sense of what PrEP at the Baltimore City Health Department looks like, we began offering PrEP in 2015 at our sexual health clinics. Our sexual health clinics are co-located with our STI and HIV clinics, and a lot of our referrals to PrEP come from our STI services. We have two clinics here in Baltimore City, one on the west side and one on the east side. We have since COVID been offering telehealth, particularly teleprep, which has been very well received and I think has increased access a lot. But we are only open Monday through Friday during business hours. We currently have as of the beginning of this month, when we put the slides together, 246 active patients. We see majority male, majority are between the age of 25 to 34. We do see we see any age. So we do have some patients that are like 16 and 17 and have also been working with a local school on PrEP, but most of our patients are 25 to 34 and a majority of our patients are Black. And we actually have an RN-led clinic model. So our nurses are pretty much leading the panels, understanding orders, which is a whole other presentation all on its own, but it's been very successful at our clinic. We have two nurses right now, one for each clinic. We have requested another nurse in our next budget cycle. We have two peer navigators ideally. We currently have one peer navigator and one open position. We ideally would have one social worker. She left a couple months ago, and we are hiring actually a status neutral social worker who will be able to work with any of our patients at the sexual health clinics. And then for the program for our providers, we have 3 nurse practitioners, 1 physician's assistant, the nurse manager, which is myself, and then our HIV PrEP medical director, who's spread very thin. She oversees both HIV and PrEP services and also works with our TB clinic. Next slide. So when we were thinking of rolling out injectable PrEP, we tend to at least try and use the PDSA model for quality improvement. And we do this for design as well. So that's the Plan, Do, Study, Act. So the biggest part of this model is really not being afraid to do the do part of this. I think a lot of people get held up on this planning part. You can make it as best as you can. And then a lot of the things you just need to see how they work out. If you saw our first draft of our first protocol, it was like 1 page long. And a lot of it was like, we'll see how this goes. We don't know how long this is going to take. We'll talk with the drug reps and see how this process will work. So just keeping in mind not to let perfect be the enemy of good. So in the planning phase, we were doing a patient satisfaction survey. And so we did before the injectable was approved, had a question related to if people would be interested in the injectable medication. And we saw pretty high interest from people in at least wanting to know more. And from that, we had some meetings internally with the PrEP team, and we had a clinical champion, Caroline, who's going to present next. She's our senior PrEP nurse, and she took the lead in really implementing this process. We then planned for a pilot phase and created the initial protocols and the draft of our initial protocols. We're currently in the due portion of our pilot. So we're piloting it at one of our clinics. Although our other clinic is also referring over to the Druid Clinic, which is the clinic that is piloting it. On the 24th of February, we had our first patient visit for injectable PrEP. It did take us a while to get the med for the first patient, just to get through all of the steps. But once we actually had put in for the med, I think it didn't take that long. And Caroline will go more into that in depth next. But we did give our first injection at the beginning of the month. And then we've also been, while doing this, been kind of going back and refining our protocol. So the next phase is the study phase. We have both qualitative and quantitative measures that we'll be looking at. So we'll be looking at ease of use, experience at the patient level and at the clinician level and the nurse level, as well as looking at the number of missed appointments, the number of successful initiations with return, and things of that nature. And then for the ACT, we'll decide whether to adapt, adopt, or abandon. And then if we do adapt or adopt it, we would move it over to the other clinic as well. And so I'm going to hand it off to Caroline to talk a little bit more about what the do phase is actually looking like these days.
Thanks, Shauna. Can everyone hear me?
Yes.
Okay, thanks. So this part of the presentation will zoom in on this do phase and what's actually happening in the clinic right now. So one of the things that I'm doing to organize myself is to just create a spreadsheet with all of the patients who are in what I call our, cabotegravir or Apretude pipeline. So I've decided to include patients who have had some sort of initial education or conversation with me, either in person or on the phone, in this pipeline, because they might be people that come back later and end up getting injections. So right now we have 6 people who've had initial education completed. We've had 1 person, like Shauna said, who got their first injection. We have 2 right now who are in the process of getting letters of medical necessity. That part has been delegated to our Druid provider. And then we have 1 patient who's, I sent their ViiV enrollment yesterday. So they're pending enrollment for ViiV PAP program. And there's 1 patient who was lost to follow-up who was actually uninsured, and we received both doses of their medication. So we have their medication, if they ever change their mind, in our Pyxis stored safe for them. And we have 1 person who has declined to move forward with the process. So that's sort of what our the 6 people, a snapshot of those 6 people. I'm also going to use this Excel sheet. I decided to use the Excel sheet to also try to track delivery logistics. So I didn't really intend to share the whole sheet, just a snapshot, but you can see that there's like dates and other details about their individual cases. And I think I need to create tabs at the bottom to really track delivery, because that's definitely going to be a challenge with cabotegravir, with Apretude. So one of the first things we did was try to figure out, how it will look to start someone on Apretude. So we made some flow sheets about, what the transition from oral PrEP might look like. And we also did the same thing for people who might be new to PrEP. But based on the 6 people that we have in our pipeline so far, most of the people are going to be transitions from oral PrEP. So that's what I'll start with here and kind of walk through it. So the first thing that we do when someone comes in and is on oral PrEP, and maybe they initiate a conversation about switching, like Shauna said, a lot of interest was drummed up around the patient satisfaction survey. And so after they took the survey, people were texting me or at their next appointment asking, like, how do I get on this? So the first thing that we did with the person that's actually received an injection was assess their adherence. If the person is taking their medication as prescribed and they're very organized, then the next thing we would do would be to obtain baseline labs. Now, for somebody who's on oral PrEP, that baseline lab might be, you know, it's pretty much going to be the same as their PrEP follow-up labs, but we'll make sure to include an HIV RNA as required for CAB. After we obtain baseline labs, we'll attempt to get insurance coverage. So we'll try to work in that 7-day window. If it's obtained within 7 days, then we'll schedule that initial injection visit. So this isn't a same-day start. There's still that lag. So they would come for labs, we would wait for the result, and then we would give the injection at a separate visit. If the coverage is not obtained in 7 days, our protocol as it stands now, we would actually schedule a repeat RNA test. So if it drags out, we would schedule a repeat test. However, we wouldn't schedule the repeat test until we have the medication in clinic. So I think that was something that in talking with our group was a good modification. So don't keep having people, you know, get test after test. You can try for the 7 days, but if it's not working, wait till you actually have the medication and then bring them back for the RNA test, review that result, and then schedule the initial injection. And if CAB is just not possible with their insurance at the time, then we'll just maintain them on oral PrEP. And everyone can see that if someone ends up being HIV positive, it's an inclusive flow sheet where we would refer them to our BCHG HIV program for a rapid ART start. We went back and forth about obtaining the need to obtain a rapid HIV test in clinic with someone who's on oral PrEP, and we thought that decision might come down to their self-reported adherence. And this is the flow for someone who's PrEP naive. So the first thing we would do would be to get baseline labs. There was a question already in the chat about whether the baseline labs would look like oral PrEP labs. And we decided for our protocol that they would mirror the labs that we get for oral. And we would include a HIV RNA test, which we actually do at baseline for oral PrEP already. So when I say they'd be the same as oral PrEP, what I mean is we would get a complete metabolic panel, and we would also get a lipid panel if the person is eligible to be on TAF. And that way, if they ever have missed visits or they have an intolerance to CAB or something changes with their insurance where we can't get coverage for them, then they'll have the option to be on oral PrEP. Also, if someone, as you can see in the flow sheet, if someone is negative, it's sort of part of our harm reduction model to just start them on oral PrEP. Like people have said, we've been over multiple times already, the insurance piece is really up in the air. So it could take someone a month, and why not have that person be on PrEP during that time? So I think I'll keep moving just for the sake of time, but the flow after they're HIV negative, even if they've never been on PrEP before, after we've offered them oral PrEP, and if they're interested in starting oral PrEP, is actually the same as the previous slide. So this is some graphic that I made up because I'm a visual person, and it helped me to kind of picture out the visits, what the visits would actually look like. Because I guess with the flow sheets, that's all happening before the first visit. So what the visits would actually look like is this. And I wanted to point out that I made a mistake on the slide, and month 1 should actually include education and counseling. We actually, you know, there should just be education, counseling, and questions asked at like every month. So we actually had one woman who was interested, the woman that actually declined to start CAB. She was an older woman who had tried Truvada, who had a history of fractures, and she actually had an HIV positive partner. So she was a really, what seemed to be a good candidate. But when I talked to her and we really looked at her risk factors, we realized that they were actually fairly low. She was in a monogamous relationship. She had trust in her relationship. Her partner was virally suppressed. And so, that's better than some situations with, a partner who you don't know their status, or you don't know their viral suppression status. So I just wanted to include that example because the conversation and the ongoing risk assessment, especially before starting a long-acting medication, I think is just really important. And we can't downplay behavioral interventions, even in the face of this really exciting new pharmaceutical. So this visual is a combination of the CDC guidelines and also the prescribing information from ViiV. So I won't really, go through all the months, but like Tamara was saying in the beginning, initiation might be different than month 1. So I'll move on. I do want to point out though, at month 12, the CDC recommendation is to assess the desire to continue PrEP. So that's an important conversation as well. So some patient education points that I try to hit. And so this would be stuff that I've talked about with those 6 patients who were interested. I try to do this up front and then sort of really at every visit after to reinforce. We talk about the medication indication, talk about the fact that it is protective, that long-acting CAB protects against HIV, not STIs, and talk about the fact that an indication for long-acting PrEP is, either desire to be on PrEP or having some risk factors for, being at risk of HIV. Then I will make sure to talk about continuing on oral PrEP, whether that means the person's already on oral PrEP or starts a 28-day lead-in while we wait for medication delivery until the first injection. Those are both options, and sort of, like I said before, our kind of harm reduction, push. I'll make sure to talk about dosing and testing schedule. So really, at this point, if someone's really excited, they've seen the survey or we talk to them because they're a good candidate, they're like, all they want to do is get rid of these pills every day. So this one, I really try to manage expectations, not only about the time to first injection, but also about like the fact that you still have to be really adherent. You're not, that's just kind of a backbone right now of PrEP, is just like a steadiness and an ability to come back to the program and to, not avoid phone calls. Like there's just a certain amount of relationship building and steadiness that you have to have anyway, regardless of the modality right now. So
Caroline, really quick, we're kind of running low on time. Do you want to start
sure.
thinking about wrapping up?
Yes, thank you for the time.
Thank you.
I also go over common side effects. I'll look at adverse effects, we'll discuss pregnancy in CAB, and then discuss long-acting CAB. And then the last slide I had was really just pipeline considerations, things that people have talked about, thinking about insurance status, medication delivery, how to organize ourselves in clinic. And one thing to think about for us has been scheduling patients. Obviously scheduling them in the beginning of the 14-day window so they don't miss appointments, but should we also kind of cluster injectable clinic visits for our clinic to make it easier to organize delivery and reminder calls and things of that sort. So that's it. I'll pass it back to Liz and Robert. Thank you.
Thank you so much, Caroline and Shauna. That is really valuable stuff, and that's exactly why I wanted us all to be able to hear about this. We're going to move on to our third provider now. Dr. Joseph Cheruby is with Washington University.
Hi, everyone. My name's Joseph Cherby. I actually work at Washington University in St. Louis, and I wear quite a few hats. I'm actually one of the PIs for the Washington University St. Louis CDC Track 2B Capacity Building Assistance Program, as well as the Associate Medical Director for the St. Louis STI HIV Prevention Training Center and the St. Louis County Sexual Health Clinic. So when I was offered the opportunity to speak to you all, I found this to be a really interesting opportunity to discuss injectable cabotegravir because I have the wonderful job of being able to wear two hats. I work in a county sexual health clinic, and I also work in a major academic health center. And so it was really fun to kind of try to parse in my head about how we are going to be delivering injectable cabotegravir, which I think is a great option for our patients. I always say more options is good options. It especially allows us to meet our patients where they are at. And so when this was approved, and we were one of the initial sites for the HPTN 083 study, this was very exciting, but of course it offered a few challenges that I'm just going to briefly go over today just to kind of, for the sake of time, because I want to get us into the discussion and the panel discussion. So just a little bit about our clinic at WashU. We have a dedicated PrEP clinic. We are still waiting to get our data from this year, but we've had around 650 evaluations from 2014 to 2021. The majority of our patients the majority of our patients are 45% are non-white. The median age is 28 and 91% are cisgender men, with 99% of those cisgender men being cisgender men who have sex with cisgender men, whereas 1% is cisgender men who have sex with cisgender women. So the advantages of our site here at Washington University is that we have an on-site 340B pharmacy. This has been a huge game changer. We've actually opened this within the last year. And in all honesty, it has changed our ability to provide PrEP for our patients, not only oral PrEP, but also gives us the opportunity to discuss a whole protocol, which I'm in charge of in working on injectable cabotegravir here at WashU. Also, having a 340B pharmacy on site, of course, gives us the opportunity in order to provide financial support, especially to people who are and underinsured. And so we have been utilizing those funds for a variety of different factors that go into PrEP care, such as providing expedited partner therapy, making sure that we can get regular STI screening, especially if there are instances in which an insurance company, despite it being federally mandated, we've had issues with insurance companies covering a lot of aspects of PrEP care and trying to navigate the billing landscape. And so our 340B pharmacy has been kind of a great safety net, but also has been integral into our rolling out of our injectable cabotegravir for PrEP or Apretude. Our pharmacists are well-versed in payment assistance programs. And so they have been very helpful in terms of trying to figure out the landscape of Vive Connect and previously the Gilead payment assistance program. So it's been really helpful for our patients to have constant contact, and then being on site and being able to contact us through secure messaging on Epic, for example, just makes a whole lot easier than it would be in any other, for example, if we were using an offsite pharmacy. We have an MA that was recently hired on our staff within our pharmacy, and the primary purpose of this MA was actually to work on providing injectable Cabenuva as well as Apretude. And so this is the dedicated job of this MA on that site. And so what this MA's job will be is to coordinate along with our pharmacy staff, as well as our nursing staff and our PrEP navigation team here at WashU, in order to make sure our patients get in regularly, are scheduled for their injections when necessary, and to do if for example, an injection is missed, to make sure to follow up with our PrEP navigator to make sure to get these individuals in as soon as possible, or to transition to oral options for PrEP. We also have a newly we've had a PrEP navigation team, but we've hired and expanded our PrEP navigation team on site, which of course allows us to meet our patients where they are at and to not only just focus on payment assistance, but also focus on other needs, kind of like a case management model of what we use within our Ryan White programs, as well as our HIV positive folks. So it allows us to actually provide more comprehensive care when it comes to PrEP provisions. like I said, we were a site for HPTN 083. I'm sorry, that should be 083, not 084. And on site, we have a prevention training center and a capacity building assistance program, of which I am in the leadership of both of them. And we have a really motivated staff who, and the reason why I bring this up is because the moment that this became available and was FDA approved, our staff immediately was like, all right, how do we get this to our patients and how do we make sure that this goes? And so we were quite ahead of the game in trying to make sure that our rollout is smooth if and when our patients are interested in being on injectable cabotegravir. So, of course, with looking at the landscape, we always wanted to look at potential barriers. I really appreciate the last team doing a PDSA cycle. I wish I had thought of that to show what our cycle was, but the potential barriers here in Missouri are such that we just passed Medicaid expansion, and our state legislature actually tried its darndest to make sure that we didn't pass Medicaid expansion here in Missouri. So it's been really hard, especially when Medicaid has been one of the major means by which we could provide HIV pre-exposure prophylaxis for our respective populations. We've also seen an uptick in issues with billing coverage for oral PrEP. I actually just gave a talk with wonderful people from NASTAD yesterday, in which we were trying to navigate the complicated billing schemes of private insurance companies and what modifiers we have to use and what billing codes work best and all of this stuff. And we've been seeing this uptick for some reason in 2022, but we're slowly getting the hang of it now. But our concern is we worry that, with this brand new drug, how can we make sure that this is going to be covered as well? And with certain insurance programs, we know that they're federally mandated to cover PrEP care, but usually that mandate is restricted to one formulation of PrEP, and oftentimes it is not the injectable cabotegravir that is their chosen medication. And so we also have the fact that the HIV-1 RNA testing requirement that is placed in the new guidelines with, really fascinating results that delay between antigen antibody testing and HIV-1 RNA testing and being able to detect acute HIV. But of course, like I said, I work in a state health department and county health department. HIV-1 RNA testing is not cheap. And so it's something that we have to consider, especially in how we implement this. And, I've had some of our providers say, well, do we really have to do that? What does it, what is the requirement? And for me, I think with oral PrEP, we've had years of experience with this in order to feel a little bit more confident in using HIV antigen antibody testing. But with cabotegravir, with that delay being up to 90 days, I think a lot of us are a little bit itchy and want to make sure, one, providing one antiretroviral therapy drug as opposed to two, we're not creating options for resistance, especially towards integrase inhibitors. There's also uncertainty with respect to payment assistance programs. With any new payment assistance program, there is growing pains. And so a lot of times, while I appreciate the fact that these payment assistance programs are out and are available and serve a very important purpose, I think that we are all still trying to feel the ground, especially in trying to, and I've been looking at the comments, and I think a lot of people on this chat are also feeling, just trying to figure out what will be covered with these payment assistance program from ViiV as well as from Gilead to a certain extent. But just trying to make sure that we know when those payment assistance programs can work and how we can make them work for our patients in the best way possible. And then just trying to figure out the frequency of labs and visits. I really appreciated seeing all these other different workflows and charts and trying to see, okay, so when are we doing, are we just going to have an MA visit for the injections every 2 months? With that MA visit, can we have a standing order for HIV-1 RNA as well as HIV antigen antibody test? Whereas for the screening for bacterial STIs that we need around 4 to 6 months, do we then do a full clinic visit during those times? And so trying to figure out when the logistics of having a full office visit versus having a nursing or an MA visit is kind of what we're trying to work out. And so again, we're still working through our workflow, but this is our current work structure that we have here at WashU. We make sure that a patient is interested in injectable cabotegravir for PrEP and provide all different options for PrEP, and try to discuss and see what works best for them. If they are truly interested, we obtain the baseline labs, such as the HIV antigen antibody test screening for bacterial STIs, And then we call our pharmacy upstairs. Like I said, I'm very lucky. I can immediately instant message my pharmacist upstairs and say, hey, I have a patient who's interested in injectable cabotegravir, and they can run their insurance status within 10 to 15 minutes, which is fantastic. And that, of course, while they're obtaining their other labs, allows us to have a lot of this conversation on the side. And by the time they get upstairs, either the patient is going to be receiving oral PrEP if they're not covered, or injectable cabotegravir if they are. Like I said, the pharmacy runs insurance program and assesses for payment assistance needs, and then tries to navigate that with the patient if they are still interested in receiving injectable long-acting cabotegravir or Apretude. If the insurance is not available, again, they have the option for oral PrEP, and we have that discussion in real time. If they qualify, they ideally, yep.
We are running low on time. Do you think you can start?
Okay, yep, I'm done. I have one slide after this, which is great. So if they qualify, they get their first injection. And then again, we all know the rest of the algorithm with respect to when they need to follow up. But with that 1 month follow-up, that would for us be an MA visit and a nursing visit in which we would have a standing order for HIV labs such as HIV-1 RNA and an HIV antigen antibody test. And then every 2 months, they would, at least every 2 months, would have those repeat HIV tests. And for every time we check their bacterial STI, we would do a full clinic visit. So we've had 4 successful injectable cabotegravir, 3 Cabenuva, 1 Apretude, 100% were on private insurance. There's much interest, but it's hard to get the same day or even within a few weeks. And so, and we're still, like I said, trying to figure out ViiV coverage, but internally, we've also had a little bit of staff turnover recently, and we have a brand new team, which is really exciting, which means we get to formulate this whole work together. But overall, we're really excited, we're motivated, and we're working to implement this. So we're still working out a mechanism for missed doses, trying to make sure that if they do miss a dose, that we get them on oral PrEP as soon as possible after that 2 months of that first injection. Ensuring coverage for cabotegravir and copay assistance, and then making sure that we train our staff as well on the best billing mechanisms. As for the St. Louis County Health Department, we're actually working and focusing mainly on trying to work on oral same-day PrEP because of the issues with funding, logistics, but also making sure that we can get access to that HIV-1 RNA testing, which is a high cost. But we're coming up with more innovative stuff in our county clinic, including trying to get same-day PrEP through our DIS, which is really, really exciting if anyone is interested. So that is it from my end, but I'm very excited to hear the discussion and to be able to partake in our panel talk.
Thank you so much, Dr. Cheruby. So I want to ask all of our providers to come to the front of the virtual room, as it were. I also want to introduce Christopher Hall, who is an infectious diseases physician who has maintained numerous roles in HIV care prevention and policy since 1987. He's here today in his role as the medical consultant to our Prevention Training Center Biomedical HIV Prevention Capacity Building Initiative. He's also the medical director at Q Care Plus, a telehealth practice offering PrEP. And he's the clinical medical director at Molecular Testing Labs, which, among other things, he helps develop remote diagnostic technologies. So welcome, Chris. And Tamara, I will give it to you to facilitate our discussion.
Thanks, Robert. So I've been trying to follow the chat, and I just first want to say apologies for the spammers. And unfortunately, I wasn't able to focus on all of the presentations at the beginning because we were trying to manage that issue. And if you have colleagues that tried to get in, we got to a certain point where we literally stopped letting new people in. So please apologize to your colleagues. And again, the recording will be available on our website, which we can post again. So I have some questions I had come up with in general, but looking at the chat, it just really looks like financing is such a hurdle. And we had a couple folks that were clearly, Carly Floyd, I know she had to step off, but she did a presentation on PrEP last week that was great. And she clearly knows a lot about what's going on in terms of the financing piece. And it looks like her program in New Mexico actually they decided after they rolled it out to put it on hold because of all these logistical issues. So that was a bit sobering, but I'm not surprised. So I'm trying to think about how to do this Q&A without being a total pessimist. And I think some of you have had good experience. Joseph, it sounds like you have great access to your pharmacy. You're also a study site, which sounds like it helped. And I'm wondering if anyone on the panel wants to kind of address those issues from the get-go. There's these issues of prior auths, but it sounds like that's not really the problem necessarily. How much money are clinics going to eat if they, inject first and get reimbursed later? Would anyone like to just start speaking to some of these questions?
Let me just break the ice. Let me just break the ice by telling everyone that I'm so impressed by the talent and the experience of everyone on this call. I don't really need to be here. And so that's nice of you to have introduced me, Robert, but this is really an amazing group. And this is exactly how we hope that the field is going to learn from one another. So thank you so much to Shauna, Caroline, Dr. Sharabi, and Jillian for being a part of this. Really, really appreciate it. You guys know so much about this. And I think I may have stepped on someone, but I was just say the one thing that I'm hearing on here that I think makes a ton of sense is, rather than thinking about our initiating people on Apretude, what I'm hearing is it's the idea of, well, let's just make sure they get on PrEP, and then it can be more of a switch to Apretude if and when we can get that approved. Because the last thing we want to do is leave patients vulnerable, right, with no PrEP coverage. As we're finding out that it's really taking a while to overcome some of these barriers. So I just wanted to put a point on that, and then I'm going to just give the mic back to these experts.
Yeah, I think that's such a good point, Chris. I think we all sort of saw injectable coming our way as being able to go for the patients that just weren't going to go for oral, but it's not looking like that's going to be the approach right away.
Yeah, so most of our patients are on oral PrEP, and we are slowly pushing them onto the CAB. And for the prior authorization, at least for me, I've had success with those two. Is I really focus on compliance with the oral PrEP, because that really is what you kind of like can vouch for, because you get HIV with the oral PrEP, because for missed doses, then that would be a better solution. So I've used that approach for both medications, and they both have been approved in that manner. So that's, and also like if, let's say like the serum creatinine is normal with both Truvada and Descovy, I go that way as well. So I find different routes to vouch for them to get the injectable. So and those two have worked so far. And I saw a question about insurances. So my case study, so far Humana insurance, definitely, and also Blue Cross Blue Shield. Those two definitely you will find they will be covered from my experience. They will add more insurances later on. And as I get more, I can share more with you.
I would also just add on to that, and I appreciate everything that was just said, but insurance coverage, of course, varies between where you are and what state. So there are resources, prepcoveragecheck.org. I keep popping in and out because I wanted to make sure to get the right name, but prepcoveragecheck.org does allow you to check within your local jurisdictions as well to see what is covered with respect to your particular location, as well as what is allowed for each health plan. And so it requires a little bit of work on the back end. But what I will say is that this is how you can also check to make sure if a healthcare insurance will cover a particular medication or not. But it's honestly been hit and miss for us. But it helps when you have a team because we're all busy, right? We're all busy folks, and we're all part of this massive machine trying to make sure to provide care for our patients. And so I think I think once you get a group of people. And once you have the resources that can navigate this difficult landscape, it makes it a lot easier. But the issue is trying to make sure that you have the resources, which sometimes they make it a little bit difficult.
Thank you. Caroline or Shauna, anything you wanted to add to any of that?
I will say that at the Baltimore City Health Department, we do not bill for services. So the only thing, so the RNA has already kind of like if somebody doesn't have, we'll bill it through insurance first, and if not, we have grant money to cover it right now. I anticipate if we had a really high volume of lots of people who needed us to pay for their RNAs, that might start becoming an issue. But we also have an HIV clinic that has a lot of uninsured individuals, although we do have Ryan White funding for that. So we can't speak too much to that billing piece, and I apologize. What we do is the insurance piece for the medications in particular, which I think others have addressed.
Great, thank you. There was a question that I know was early in the chat about what to do with leftover medication if it's ordered for a patient and you have it. What I know many of you don't have that many patients yet, but for those of you who don't have a pharmacy who I assume can stick it back on the shelf, what is your plan to do for patients who don't end up using their drug?
You mean for their injectable cabotegravir that is unused?
Exactly.
So I can't speak to that. We have an anti-brown bagging policy here, unless it comes from our pharmacy itself, then we would know where it is, and we're storing it in our pharmacy. But it is a very difficult question. What I will say is, and I'm not sure if there are any pharmacists on, but how many doses are in each vial would be an essential question to know. And if it's a single dose per vial, then that answers that question for you. But if it's multiple doses per vial, then it might be a little bit more difficult. But I won't pretend to be well versed in how many doses are in each vial.
Well, we definitely have pharmacists on the call. Jillian is a pharmacist right here.
Yeah, it's only one dose.
Yeah.
It's only one dose. Yeah, it's a kit.
And right now, I think the issue is the only specialty pharmacy, and thank you, Cassandra, in the chat for putting that, is Walgreens right now that's contracted with ViiV. So that obviously is a barrier.
Yes.
We do have one patient who we initiated the process for and then never came for their first injection, and we do have their second injection as well. I believe he was uninsured, so that was filled through the ViiV PAP process. So I imagine we're going to keep it because we're still going to try and get him in care. If he really has fallen out of care, we'd reach out to ViiV, I guess, to see if they would want it back. I can't imagine that they would take it back. So we'd probably just dispose of it.
So go ahead.
Yeah, no, go ahead.
So we have had that happen, not with that medication, like with Truvada, Descovy. So we just keep it in the clinic at the right temperature for storage. And we have had cases where people need NPEP, and it was like very close to the window. So we have used it in that case. Like we had a patient who needed NPEP and needed Truvada, and it need and they had like a 3-hour window to get it from the insurance. We need a prior authorization. So we just gave it to that patient because it was sitting there like for 6 months. So we just keep it in case we do need it. So somebody else can use it.
Tamara, could I butt in with one quick question?
Yeah,
would one of you just remind us of what the storage requirements are for Apritude?
So in the clinical trial, which I was going to be part of, but did not start, it's up to 84 degrees. So it's room temperature, but it does come cold, like in a cold chain, with ice, with cold bags, fridge bags, but it's up to 84 degrees is the maximum temperature to store it.
So there's an interesting question that just came out of the chat from Patrick. For patients who are currently using patient assistance programs like Advancing Access or Ready Set PrEP, for oral PrEP, are there issues with obtaining approval for the ViiV patient assistance for injectable CAB? So can a patient be on oral PrEP with a patient assistance program while going through the approval process for the cabotegravir ViiV patient assistance?
Yes. Oh, sorry. Go ahead.
Oh, sorry. No. Okay. Yeah, our uninsured patient was on the Gilead PAP program and then switched to the ViiV PAP program. So I'm pretty sure with these patient assistance programs, they do check for insurance, but they don't check for other patient assistance enrollments, as far as I know. So the answer is
kind of
yes.
a overlapping scenario that you're
They
talking
can
about.
be overlapped, yeah.
Great. Anyone else want to say anything to that? Okay.
Patrick, I saw you raised your hand. Did you, do you have a follow-up to that or something additional?
Thank you so much. I just wanted to make sure because my question is because currently patients with, like, for instance, if a patient's on Gilead's Advancing Access, you cannot enroll them in Ready Set PrEP. So my logic makes me think that if we're trying to enroll them in a patient assistance program through ViiV, it's going to flag that they have some form of pharmacy benefit. So which may result in additional manpower or hours trying to show proof that they have a patient assistance program with another benefit like Advancing Access or Ready Set PrEP.
Hey, Patrick. Yeah, that wasn't my experience with the person who I switched from or attempted to switch from Descovy, who was on Gilead Advancing Access PAP to injectable PAP with ViiV. So that wasn't my experience.
Yes, I'm gonna agree with Caroline as well. And the reason why, Patrick, that this is happening is because Gilead and they use the same portal, which is called iAssist. So that portal tracks and knows that they are enrolled in Gilead. So if you try Ready Set PrEP, it's gonna flag that because they use the same exact portal to get the approval. So that's what.
Yeah, and I think Monica Levy in the chat pointed out that when you're doing PEP, you can have patients enrolled in both Gilead and ViiV for the two PEP medications. So it's similar.
Is this a good time maybe
That
to
makes
ask?
sense.
If,
I wanted to move on maybe to one thing which has the potential. Oh, go ahead, Robert.
I just wanted to ask, is maybe a good time to have a quick answer to why oral cabotegravir is used for either lead-in or for interruptions in injections if it's not an approved PrEP medication?
Sure that Joseph can answer this, but it was originally part of the HPTN 083 protocol because we didn't know the extent to which there might be adverse reactions to cabotegravir and how frequently they might occur. So the idea was use an oral lead-in to ensure the patient can tolerate the drug before exposing them to a long-acting version in the form of the injectable. That was the original reason, and others have reason. Anything else you want to add to that?
No, I think this is just a trend that we see in the majority of clinical trials these days, is especially with an injectable version, they want to make sure that there's no adverse reaction. And so I think that's a great question. I really appreciated that because it made me think, why not? But it is just as an availability for a lead-in for that, just to make sure that you're not having any adverse reaction or and that's pretty much the only reason. But again, if someone is on injectable and wants to be on injectable cabotegravir, I'm sure that they would want the injectable over the pill. But it's nice that the pill option is there, especially as an oral lead-in.
And someone's asking if any of you on the panel are using the oral lead-in.
I mean, if a patient really wants it and is very worried about it, we would, but we are following a patient-centered approach, and I don't think any of them have asked for it yet. Caroline can confirm that.
No, no one wants to take more pills.
And then there is the, as Dawn points out, the recommendation to maintain cabotegravir levels for delays in injections by doing oral cabotegravir. I was hoping we could spend a few minutes. I know we're talking a lot about trying to get patients on injectable PrEP, so it almost seems too soon to have this discussion, but I am very curious to hear what all of you are finding with your discussions about the tail with patients and how you're counseling patients about the tail and kind of what your plans are to address that. I imagine it's a bit down the road, but I think it's a good thing for everyone to start thinking about. So whoever wants to jump in, please feel free.
So we kind of did project that. So our patients, they switch in and out of insurances. So they would go on Discovery, they switch insurances, they lose insurance. So we tell them upfront, we are going to try to get you the injectable. However, if there are any insurance issues, we have to go back to oral medication. We put it out there so that they don't get, mad that they can't take it anymore. So, and if they do lose insurance or the insurance is not covering it, and there's no way for them to get the injection, then we will switch them back to Truvada or Descovy. It hasn't happened yet, but we are prepared for that, and we do let them know ahead of time, hey, this might happen, but don't be upset.
So this is the same discussion that we have with PrEP in general, right? Like, you want to make sure that you explain to your patients what are the positives and negatives of any situation, the pros and cons, and what might happen, and try to make it so that they're not surprised when anything comes in. So I'm really happy to hear, that whole discussion of, if insurance does decide to change on us, then they're already prepared and already know what that looks like. What I will say is, I just have an open discussion with them about the nature of cabotegravir, right? If you are to stop it, if you want to stop it, what's going to happen is that those levels are going to drop. And if those levels do drop, then there would be, and you continue to have sexual intercourse without a condom, or if you have other STIs, then there's an increased likelihood of you acquiring HIV that might be resistant towards this particular medication. Similarly with oral PrEP too, right? We see the same thing. If you're not taking it daily, then with decreased use and decreased drug levels, then there is a risk for developing tenofovir or emtricitabine resistance. And so it's just making sure that you have that discussion with them, but also telling them, hey, if you want to stop this at any point, please let us know, right? Just let us know. We can see if we can switch you over to an oral regimen. We can discuss what options are available. We can discuss what it looks like to slowly taper off of PrEP. We could discuss, for example, if they want to be on-demand dosing for TDF, FTC. There's so many different options that we can discuss, but it all starts with open communication with the patient and just trying to make sure that they know what to do in every scenario and how to have that conversation, even what questions to ask. But I always tell them, if you want to stop, please let me know. Just let me know, and we'll talk, and then we can counsel them about it. But I think it's something that we are, I think with it being a long-acting injectable, it's just we see it, right? We see that tail more so than we would with oral medications and the declining drug levels.
And we have just a couple minutes left, so maybe time for one more question.
Shauna, did you or Caroline anything to say about that?
The only thing I wanted to add to Dr. Sheraby's answer, which was very thorough, was that I'm thinking about in our clinic, if there is open communication and we talk about the person not wanting to be on cabotegravir anymore, injectable cabotegravir, maybe having some sort of, or maybe this is even in the beginning when they start, some sort of contract or agreement that we have to commit to quarterly HIV screenings with an RNA test, as is recommended in the CDC guidelines, to make sure they sort of stay in our bosom, so to speak, for that year while they're at risk of developing this mutant strain, theoretically. So
And
that's the
one
only
more-
thing I would add.
One more thing I would add is, like, I think the reason we're really thinking about this really hard is because if someone were to develop HIV, they would then be resistant to the only injectable HIV treatment. It's something we certainly are taking very seriously when we're having these discussions with people.
Okay, thank you so much, everyone. As predicted, we kind of had to rush through this, and I know that we could probably stay here for another hour and a half with all of the interest in this. So I want to really thank all of our panelists, our providers who came here today so we could learn from their experience. As you can see, we have 3 final poll questions and would love to hear from you on those. I put links in the chat to the ViiV Patient Assistance Program application and also to our learning community website. And if you haven't signed up for that, that would be a good way to continue to get information on this subject and to hear about future trainings. I've been very interested in the chat to see all the people that are interested in working together, for forming a working group. And I think that's what it's going to take from us at this early point. So thanks, everyone. And I hope you have a lovely rest of your day.